Hello everyone. Welcome to the online module of the ventilation workshop as part of the Kerala State Neocon 2023. We're going to start off the sessions with nasal Cpap therapy in the NICU. This will not have a station in the physical workshop, but we're going to have only as part of the online module. So if you have any questions and doubts regarding Cpap therapy, feel free to post in the WhatsApp group created for the same purpose. So our objectives for today, we will review basic lung physiology. We'll understand what are the physiological principles for use of CPAP, what is the evidence for the benefit of CPAP use in NICU. We'll find out what are the different types of devices and their interfaces, how to nurse a baby with CPAP, when do we use CPAP in the NICU, what is the monitoring complications we can expect, and how do we wean from Cpap. Let us see how uh, the lung development and what is the physiology of the lung in neonates and specifically preterm neonates, and how are we going to help by using a Cpap. The slide that you see is showing the different stages of lung development in the fetus. The first three stages show how the respiratory ducts, the bronchi and the bronchioles form. And by the canalicula stage, we have the respiratory bronchioles. But most of our preterm births happen in the saccular stage, that is between the 24 to 36 weeks, and where the rudimentary alveoli form, but the alveolar walls are still thick. The alveolar epithelium is not fully developed, so the type 2 alveolar cells are less in number, they're not matured, surfactant is not produced yet. The production starts between 30 to 34 weeks. So this is the stage where most of the preterm births happen. If you see alveolar stage, you see that the alveoli are well formed and there is increase in the number of alveoli as well. Surfactant is fully present. So that's the difference between saccular stage and the alveolar stage. So our challenge is that at preterm births, we are trying to ventilate lungs which are not fully normally formed and their function is very suboptimal. And also that because we are treating a developing lung, we need to be careful about what effects our treatment is going to have on future lung growth and development of chronic lung disease. Okay, now let's hark back to physiology, and this is a graph showing lung volumes. And our specific interest is in something called functional residual capacity. So this functional residual capacity is the amount of air that is left in the lung after a normal breath cycle. So if you breathe some in a tidal volume state, and whatever is left in the lung at the end of expiration is called FRC. This FRC helps in preventing total collapse of the lungs at the end of expiration and has several advantages um, as to why we should be breathing at FRC. Actually, all lungs are by nature at FRC, and therefore their work of breathing is at this optimal level. But what happens is when preterm babies or newborns who have respiratory issues are not able to maintain FRC by themselves, we need to make the lungs come to a state where they can have FRC. So the tendency of the lung to collapse is balanced by the tendency to spring outwards. So this is how a lung maintains functional residual capacity. So consider if you have two balloons and one is completely collapsed, one is partially inflated, and try blowing the balloons, and you can find that the completely collapsed balloon, you take a lot more effort to open it up compared to a partially filled one. So that's how lungs also work. The additional advantage of having FRC, in addition to decreased workload, is that there is a volume of air where gas exchange can still happen even if there is no active breathing happening during that time. So it functions also as a safety mechanism when somebody has a prolonged breath holding or an apnea. There is still some amount of gas exchange happening here. So breathing at FRC reduces atelectotrauma. Atelectotrauma is the injury that happens to the alveolar walls because they collapse completely, and then during the next inspiration they are made to blow up. So repeated collapse and expansion will cause shear stress and epithelial injury leading to pulmonary edema. So all this is prevented if you are at functional residual capacity. So, and the concept also is the pressure volume loop. We know that the this is the lungs PV loop, and I think all of you are aware of this. At zero, when there is no volume and zero pressure, right? And we are increasing the pressure as we go, the volume of the lung increases. But it is not a linear relationship. It doesn't go like this. So what happens is it goes slowly at first, and then at a certain point, there is a sudden increase in the volume of lung as the pressure per unit increase in pressure. So that area is called lower inflection point. So this lower inflection point is of particular interest to us because when we are mechanically ventilating or giving CPAP to babies, we need to make sure that what we are trying to make sure is that we are not ventilating in this zone of atelectasis. So if we give PEEP of 2 or you're not ventilating with PEEP, every time there will be collapse of the lung at the end of expiration and then they inflate. So that will cause atelectotrauma. So we need to have PEEP so that we are above this lower inflection point. Coming to what are the causes of respiratory distress in neonates, the most important and most common in preterm infants is the surfactant deficiency. So pulmonary surfactant is is produced by the type 2 epithelial cells. Um, It reduces the alveolar surface tension, so thereby it facilitates alveolar expansion. Gas exchange happens because the alveolus is open, uh, therefore reduces atelectasis. When you have decrease in surfactant or surfactant is inactivated due to any reason or the quality is poor, so you can have alveolar collapse. When collapse happens, the baby tries to expand stiff lungs by increasing negative intrathoracic pressure that will cause retractions. Atelectotrauma will cause epithelial injury and pulmonary edema. So basically, lungs are not at FRC in RDS. So other causes of distress in neonates include transient tachypnea, which have inadequate fluid removal from the lungs that causes poor gas exchange. Meconium aspiration has multiple physiologies, including atelectasis, hyperinflation because of bowel-valve effect, inflammation because of pneumonitis, and there is also secondary surfactant deficiency because surfactant is inactivated. Pulmonary hypertension happens when pulmonary blood vessels do not dilate and therefore there is hypoxemia. Other issues that can result in distress including air leaks, pneumonias, congenital heart disease, congenital lung anomalies themselves can all cause distress in neonates. So now let's come to the definition of CPAP. So CPAP is a form of ventilation in which constant level of pressure uh, greater than the atmospheric pressure is continuously applied throughout the respiratory cycle to the upper respiratory tract of a spontaneously breathing person. So the most important parts of this is it's a constant level of pressure. It doesn't vary whether it's inspiration or expiration. It's given through both inspiration and expiration, and the patient should be spontaneously breathing. So this is called CPAP. So what are the effects of this CPAP? The physiological effects. So we can see the CPAP in this graph. This is a 2002 study on premature lambs. See that the pressure is on the x-axis and the volume is in y-axis. As the pressure increases, um, the volume also increase. And these are at different levels of Cpap, and one is at mechanical ventilation. So this is Cpap 5, and this is Cpap 8 at the top, and the lower is the mechanical. We can see that Cpap had a good amount of lung volumes were able to be generated in premature lambs, even when they are on just Cpap and not mechanical ventilation. So what are the other effects, physiological effects? One thing is that it increases FRC, it abolishes grunting, um, increases the PaO2, work of breathing is reduced, tachypnea is reduced, it maintains minute volume, and the PCO2s are better. Whereas it also decreases pulmonary vascular resistance by improving hypoxemia, and therefore the VQ mismatch is also reduced. See, the other effects are the stretch receptors are activated. It stimulates the Herring-Brewer reflex. That causes decrease in tachypnea. The dead space is reduced. Therefore, there's better ventilation because more amount of lung is open. The expiratory time increases as the end expiratory volume increases. So the rate also comes down again. Airway resistance is decreased. Airways are splinted, they are kept open. And the other thing is surfactant is also conserved because of the reduced inflammation in the lung. The capillary leak gets reduced, and that helps in conservation of the surfactant, and endogenous surfactant production also is improved. This is just on the slide showing Cpap and pulmonary vascular resistance. So we can see that when the lung is at FRC and not at residual volume or total lung capacity, the PVR is the least. The total PVR is the least when the lung is at functional residual capacity. So this is important even for cases like pulmonary hypertension. The administration of Cpap will help in reduction of PVR. Cpap also has an effect on apneas. It decreases obstructive apnea because it splints the airways. It prevents them from collapsing. It reduces central apnea by reduction of hypoxia, and there is also a flow constantly in the nose, which helps them stimulate to breathe. As we had already seen, so there are several animal studies which showed that preterm lambs, had when they're treated with Cpap, develop less inflammation versus those who were given mechanical ventilation. So it all reduces all traumas, electrotrauma, volutrauma, barotrauma are all less with Cpap. There's better growth because Cpap helps in distension of the lung, which is similar to how the lung is distended with fluid in utero, and that helps growth of the lung. It also leads to better alveolization as seen in several animal studies. So this is a baboon study where they saw that the A is preterm lung at birth, and this is the term control. The C is the lung which was preterm lung, which was treated with Cpap at birth, and this was the tissue that was taken at 4 weeks of life. It shows good alveolization, breast formation, which is comparable at least to a certain degree with B. D is the tissue that is taken from a preterm baboon which was treated with mechanical ventilation. And again, this is at 4 weeks. You can see that there's less septation, less alveoli development compared to the Cpap lung. So that's the reminder, is that not just in HMD. Cpap can be used in several causes of respiratory distress in the NICU and should be used as a primary respiratory support in newborns because of the multitude of the effects that it has on the lungs. Let us just quickly review the evidence about the benefit of Cpap use in the NICU. So in the 90s and early 2000, there were several small RCTs which showed benefit for use of primary Cpap as opposed to intubation for all extreme preterm babies at birth. So, and there were a lot of other RCTs which followed, large RCTs, which established that primary Cpap at birth is beneficial uh, vis-a-vis ventilation and surfactant administration. The first of those studies is the COIN trial, which was published in 2008. The large RCT of 16 infants, and they were all extreme preterm infants for 25, 28 weeks. They were randomized to receive either intubation or Cpap at around 5 minutes after birth. So it showed that around 45% of these very tiny babies in the Cpap group did not need intubation. And there was no difference in BPD or death at 36 weeks, and they had slightly better oxygen needs at 28 days in the Cpap group. The only negative effect from here was there was a higher pneumothorax rate in the Cpap group, which is probably related to the higher threshold that they had for surfactant administration. They gave surfactant at a higher FiO2 than we do currently, and they also used higher PEEP levels. The support study group, this came out in 2010, and this was again a big study. Again, very small infants, 24 to 27 weeks. But here in the Cpap group versus the intubation and surfactant group, the Cpap group, almost 80% of them required surfactant. So there was no difference in BPD rates. They were the same, but the only thing was the Cpap group needed less postnatal steroids. The Qpap study group, this was the, again came out in 2010. This is again 208 infants between 25 to 28 weeks. Well, Ensure was compared with Cpap and rescue surfactant. Almost 50% of the Cpap group did not require surfactant, and there was no difference in BPD at 36 weeks. There was no difference in death or secondary outcomes. So these studies established that Cpap is safe, and almost a significant number of infants can avoid intubation and surfactant if we give primary delivery room Cpap to even extreme preterm infants. So there was a meta-analysis done with all these RCTs in 2013, which actually showed that early Cpap reduces BPD in extreme preterm infants and should be the standard of care for them. Now, there is also something called prophylactic Cpap, that is to start them very early, immediately after birth, to start Cpap with a face mask using a T-piece to extreme preterm infants. So it's become the standard of care. There might be slight slight benefit in reduction of BPD in less than 32 weeks with this approach compared to supportive treatment and later Cpap. However, there is some small risk of apnea when we use face mask on these infants, and that we must keep that in mind. There are European guidelines for HMD released in 2022, which ask us to start delivering Cpap at a level of 5 to 6 centimeters using a T-piece mask for all preterm babies. The other thing that is coming out new is that NIPPV is probably slightly better than Cpap at preventing treatment failure, that is intubation, and BPD. So this is something that we might hear more in the next few years. Now let us see what devices and interfaces we have with us to use Cpap in the NICU. So there are two kinds of devices. One is called continuous flow opposition device. One is called variable flow machines. So in the continuous flow, you have ventilators which deliver Cpap, and the bubble Cpap machine, which we are all very used to in our NICUs. The variable flow machines, like the influent flow, the Viasys, Medijet, these are more used abroad. They're actually supposed to be better than the continuous flow in many ways. So variable flow Cpap, this is the nasal prong side. This goes into the nose of the baby, and where close to the nasal prongs, there is a small jet injector, where a strong stream of jet pushes the air mass. So during inspiratory flow, this is how the jet mass will push air into the baby by creating and thereby deliver Cpap. Whereas during exhalation, because you don't want to have so much pressure going in, there is a fluidic flip. The inspiratory gases flip into the expiratory limb of the interface. So this is how variable flow works. So the flow changes in both inspiration and expiration. So this is the infant flow CPAP delivery system. This is the machine. These are the prongs, and this is the mask. This is how it is applied to the baby, and this is widely used in abroad. So variable flow CPAP has many advantages because it's baby friendly, because there is increased flow during inspiration, there is less asynchrony, so baby is comfortable. It fights the CPAP less. Um, it decreases the work of breathing more than the other systems. So there is also a lot of evidence that there is, compared with the continuous flow systems, there is better oxygenation, less duration of support is required, work of breathing is less, apneas are less with variable flow. So bubble CPAP is the machine that we are all very comfortable with. Dr. Wang in Columbia in New York perfected this machine. So here blended humidified flow, blended oxygen, which is sent to a humidifier, heated, and then it is connected to the inspiratory limb. The expiratory end is connected to the water seal, which will maintain pressure. Your pressure can be changed by moving the expiratory limb in the water. The nasal interface can either be prongs or masks. So expiration underwater produces constant bubbling, which oscillate at around 5 to 10 hertz. So there is a little bit of oscillatory physiology also that is helping in a bubble CPAP. So bubble CPAP is easy to use and maintain, and therefore in resource poor settings, it is widely used. So bubbling like oscillation increases recruitment and better gas exchange. Oscillations become better if there is a worsening of compliance and further help in reduction of the disease state. So generally, variable flow CPAP devices are better than continuous flow, but there's one small RCT which shows that bubble CPAP is better in HMD. This is the bubble CPAP setup. So this is the blender. The oxygen flow comes through the blended oxygen into the humidifier, where it's humidified and heated. The inspiratory limb, which is heated, goes to the baby. And this is the baby's interface. And then this is the expiratory limb, the white color, and which is connected to the underwater. This is the let out. So water is filled here. So this is the basic setup of the bubble CPAP. I'm sure all of you are aware. So there historically, people have used several interfaces like endotracheal tubes, face masks, head boxes, nasopharyngeal tubes, single nasal prongs, while for delivery of CPAP. Some centers still do single nasal prongs, but most common use is with binasal prongs and nasal masks. So binasal prongs are standard of care. They have shown to improve clinical outcomes better than the others. However, nasal septal trauma is a concern in them. Nasal mask is an alternative. Nasal bridge can be injured with a nasal mask. And also one more problem with this is that the wrong size can occlude nerves. So both nasal prongs and nasal masks can be used. And actually in our unit, we use them simultaneously. That means we cycle prongs and masks every few hours so that the pressure site is different, and so while the septum is having some pressure when the use of mask, in the use of prongs, the bridge is allowed to heal, and the vice versa happens when we use a mask. So these are the Hudson prongs, and this is how the fixation happens. These are the Fisher-Paykel pinasal prongs, and this is the mask. And you have different sizes of prongs and different sizes of masks, and there is manufacturer gives guidance to measure the size of the nares and how to use and which size to use when. So how do we start Cpap? So once we have decided that a baby requires Cpap, so we commence at about 6 to 7 centimeters of PEEP. Um, we personally do not use more than 7 in our unit, but there are a few units can go up to 8. Flow is generally set at 6 to 8 liters per minute. Check with again the manufacturer's guidelines. You can set flow as low as possible to achieve the required pressure. FiO2 has to be titrated to the oxidation target levels. Compulsorily use a blender. The gases have to be humidified and warmed. And the other important thing is we have to position the inspiratory limb above expiratory limb, and we should use the lowest port in the incubator so that if there's any condensation happening, it will drain away from the baby. What do we monitor when we are on Cpap? Obviously, we look for whether our treatment is working or not. So we need to make sure that the respiratory distress, FiO2 requirements, CO2 trends, metabolic acidosis, X-ray picture, and hemodynamic status, whether these are all improving or worsening. We should also check whether there's skin integrity and position changes should happen every few hours. Recheck the Cpap, that it is bubbling or not if there is no improvement. Same time, so recheck if your interface is appropriate and it is having a good seal. Any water that condenses in the tubings can increase the pressure delivery to the baby, so that needs to be drained. Consider using a chin strap if you have a very poor seal where you're not able to deliver enough Cpap, but be mindful that it can increase pressures to dangerous levels sometimes. So Cpap failure, when does that happen? When do we call it Cpap failure? Is the FiO2 requirement is more than 30% in extreme or very preterm babies, and more than 40 in slightly bigger preterms, despite the maximal Cpap according to the unit policy. If there are increased apneic episodes, work of breathing continues to increase, which is reflected as the baby getting tired, or increase in metabolic acidosis and lactate levels. PCO2 is climbing up more than 60, or there is any development of air leaks, so we'll call that Cpap failure, and the baby will need to have other modes of treatment, most likely intubation and surfactant if needed. So ensure proper delivery of Cpap. We have to remember that Cpap is effective only if it is delivered. So it is not enough if we start Cpap and give the order and go. We must be at the bedside, make sure that the bubbling is happening and the baby is getting what we have ordered. Weaning from Cpap, how do we start weaning? Once we know that the baby is clinically improving, that means the respiratory distress is better, your FiO2 requirements are less than 25%, your CO2s are normal, apneas are not there, bradycardias are better, so that time you can start weaning from Cpap. But first we should wean the FiO2 before we start decreasing the Cpap pressure. So wean incrementally by about 1 centimeter from whatever level of Cpap you are to about 4 to 5. Once you are around 4, or if on bigger babies around 5, you can directly take off the Cpap if the baby is on 21% oxygen. Follow-up of weaning is essential, so babies can become distressed again and they can go back to Cpap, and we need to watch them carefully. So early weaning, which does not follow a protocol, might result in increased distress and thereby actually even necessitating intubations for that baby. So weaning has to be in a protocolized manner. So when you take off CPAP, many units just take baby from the minimal CPAP when the baby is on 21% to room air. But there is something called cycling of CPAP where CPAP is given for a few hours and then not given for a few hours. And then the off time is increased gradually and the baby is finally off CPAP. So few units practice this. There is not much evidence to say that it is needs to be done. So what complications can you see with CPAP? You can see that there are pulmonary air leaks, especially when we are using high levels of PEEP. May increase the chance of pneumothorax and or when there is a severe HMD um, and that can also lead to development of pneumothorax on CPAP. CPAP can cause pain and especially that's an issue in bigger term babies or largely preterm babies because the flow is through the nose and mouth and they have a tight cap and interface all tied around them. They will not like it very much. So pain treatment might be required in those babies. Because there's a lot of flow that is going into the mouth, the abdomen also can get distended and that can cause feeding intolerance, which is called CPAP belly. So frequent aspiration of air is important. We can use the slightly lower flows to decrease the abdominal distension with CPAP. Hyperinflation of lungs can happen when we do not start weaning CPAP when the baby has become better. So this can lead to lower venous return, fall in blood pressures that can cause increased lactate and metabolic acidosis. So, and the baby can start to look sick again. So we need to also be mindful of when the baby is better and when we should start weaning CPAP. The other important problem with CPAP is the pressure injury on the skin. So skin protection on CPAP is very important, and we did a study in our unit, and we've seen that if we have an deoderm, that's the hydrocolloid dressing on the areas where CPAP interfaces come in contact with the skin, um, we apply it for all babies who are on CPAP. The cap should be straight and it should be pulled over to the eyebrows and over the ears. The nasal tubings, the interface tubings should be supported and they should not be too tight. Watch for early changes in the skin so that every 3 to 4 hours when we need to take off the deoderm and check how skin is, we do some gentle massage of the skin between the interface changes. Most important, the prongs and the mask are cycled every 3 to 4 hours so that the pressure points change. And while we are fixing, ensure that there is not too tight. And the fit of mask and prongs also should be ensured properly. We also use a CPAP checklist for all babies so that we know that all these preventive measures for skin injury are followed and a checklist is done for each baby who is on CPAP. So I hope that it gave you a gist of CPAP therapy in the NICU. Very happy to take questions and doubts in the WhatsApp group. Thank you all.